Hi guys, welcome back. The next topic that we're studying is about Muhammad Ali. Well, you would be wondering the topic written is Parkinsonism, whereas I'm talking about a heavyweight champion. In fact, a heavyweight champion for 10 consecutive years, that is Muhammad Ali. Well, the reason behind that is that this heavyweight champion suffered from Parkinsonism. He was one celebrity who actually increased the awareness of this disease. And you see, people who are in body contact sports, mixed martial arts, or boxing, where they are boxing without any protective headgear, the heavy duty punches to the side of the head can actually contribute to microscopic bleeds in the basal ganglia. These bleeds in the basal ganglia will accumulate over a period of time and will start resulting in the manifestations of the disease in the form of bradykinesia. So the punching speed of Muhammad Ali gradually started reducing, and by the time he finished his career, he actually started having neurological symptoms. In fact, the last bout, if you read the biography of Muhammad Ali, in the last bout that he fought, he actually was having full blown symptoms, including that of tremors, but he still decided to bring it on. He still decided to fight the fight per se. And unfortunately, I mean, obviously, the career of any boxer will end one fine day. He was a superstar for 10 consecutive years, and look at what boxing did to him towards the end. He became wheelchair bound. In fact, Muhammad Ali was called or declared as the athlete of the century in 2016 Rio Olympics. You see, the Olympics were scheduled to happen in 2020 in Japan, but you know that they were cancelled because of COVID 19. Now, when Muhammad Ali was called as Athlete of the Century and was called on the stage to say a few words, the king of the ring, whom nobody could stand up to, did not actually walk onto the stage. He was brought on a wheelchair. He was developing so much of bradykinesia that actually he could not even physically ambulate himself. You can notice his characteristic mask like faces. You can notice the partial flexion in the arms of this guy, and I'll explain to you regarding the stooped posture that these patients would be having. I have given this example of celebrity just to highlight what body contact sports can do to an individual. Well, as we are familiar, the neurotransmitter which will be hampered in this case will be dopamine, and the area of the brain that would be damaged would be substantia nigra. Now, I'll be comparing these manifestations with that of Alzheimer's disease, which has been discussed earlier in the app. I want you to remember per se that from pathology domain, there would be Lewy bodies that would be encountered, and they have gone deep enough in pathology to actually ask you regarding the composition of these Lewy bodies, that is with the help of a protein which is called as alpha synuclein protein. If you compare this with Alzheimer's disease, you will remember that the neurotransmitter compromised is acetylcholine primarily, though I've also talked about deficiency of noradrenaline as well as serotonin, but the primary answer is acetylcholine. And where is the damage present? So it would be in the medial part of the temporal cortex. The specific answer would be nucleus of Maynard Bezalis. In fact, we will be talking about comparisons of alpha synucleinopathy versus a taupathy. I repeat the fact once again. I mean, why are we discussing it is because you are familiar that in Alzheimer's disease, the inclusion bodies would be called as Hirona bodies. I want you to be comfortable with it. As you are comfortable with Negri bodies for rabies, the same level of comfort should be present here. And the chemical composition of Hirona bodies is tau protein. So lots of time you will read the term taupathy. I'll explain the disorders to you that are included in the list of taupathy, but at the moment, two informations that are must know for you are taupathy and alpha synucleinopathies, or Alzheimer's and Parkinsonism respectively. Over and above this, from Parkinsonism domain, I want you to not only remember that it is substantia nigra that is hampered, there is an imbalance also happening, that the activity of the thalamus, please remember, thalamus is the pain relay center, but ultimately some parts of the thalamus would play a role in motor activity control as well. So thalamic activity is found to be relatively reduced. In contrast, a basal ganglia which regulates the activity globus pallidus. There is two types of globus pallidus that you are aware from anatomy, no? Globus pallidus interna and externa. So alphabet I subscript here talks about interna. The activity is increased. So what I want to say is that there's going to be an imbalance between these two parts which regulate the motor activity, which results in akinetic mutism. When they put a mic in front of Muhammad Ali and said, "Sir, can you say a few words?" The king of the ring could not speak a word. He could not speak because he had suffered from akinetic mutism. Now, please remember that I'm not saying that his Broca's area was damaged. You see, if a person is having stroke, then there's a possibility that the dominant parietal lobe, the Broca's area is damaged. Therefore, the speech output would be hampered. In this case, there would be rigidity of the vocal cords and akinetic anyway because of the imbalance occurring in the body. So initially, these patients will become slow, so slow that he gets up in the morning, He's going towards the washroom, but by the time the person reaches the washroom, the urine or the stool might be passed. Not that I'm saying incontinence. What I am trying to highlight is that these persons would not be able to reach the bathroom on time. As a result of it, you see, I highlight the fact once again. There is no problem in the anatomy related to the bladder. There is no problem in the anatomy related to the rectum. What is happening in this guy is because the body is too slow, the pressure will keep on building in the rectum or in the bladder. So these patients might even require a diaper in the later phases of the illness, because the hygiene component would be compromised. Once we had a look at the baseline information here, I will now be explaining to you regarding the causes why Parkinsonism would be developing in a patient. In fact, lot of multiple choice questions, you will read the word, the leading cause of Parkinsonism is Parkinson disease. In fact, when you read this, it itself looks very surprising. The topic we are discussing is Parkinsonism, and one of the causes of that is Parkinson disease. Well, what is Parkinson disease? It is a age-related neurodegeneration. The previous neurodegeneration that I spoken about is Alzheimer's disease. Now I'm telling you one of the second most common neurodegenerative disorders that would be presenting, or you would be seeing in your practice, or would be coming in multiple choice questions. The reason why this age related neurodegeneration can occur can either be genetic or it can be sporadic as well. So it is not a guarantee that if father is having the disease, then son would also be having it. That's what I'm trying to imply. And there are multiple genes involved, which you can actually read from the pathology component as well. One of the genes that I want you to remember is referred as PARC gene. And in fact, the current name for that is PARC SCN4A gene. This is one of the common genes that is basically asked. And the pattern of inheritance can be autosomal dominant, which means the fact that it could be transmitted across generation. Another gene that you will read across is called as PARC-IN. The word is IN. This is sitting on chromosome number 6. So the details for genes I would like you to read up from the pathology domain, but the important ones that I've highlighted, I'm not saying that these are the common ones. All I'm saying is that these nomenclature should definitely be clear to you. So we could either be having a genetic basis or a sporadic onset Parkinson disease, and lots of MCQs might either use the word primary Parkinsonism or might just say the word typical. Now, what is the difference between typical and atypical Parkinsonism is that typical will show a very good response to levodopa, whereas atypical will show a poor response to levodopa. The examiner wants to see whether you know this or not. So he might actually put up in the MCQ what is the leading cause of secondary Parkinsonism. The moment you will encounter the word secondary Parkinsonism, you will shift your answer from PD to drugs. Now, what are the drugs that are responsible? Well, you know that from pharmacology. Antipsychotic drugs. Which ones am I talking about? Haloperidol. It could be haloperidol or chlorpromazine, or in fact, when you are using anti-vomiting drug, no, lots of time when you would have given Perinom to the patient, that is the anti-vomiting drug metoclopramide, even then, because it will reduce the dopamine levels in the brain, there could be development of dystonias in a patient. So definitely you need to be familiar with the drug part. Now, what is the problem in the drug part is that the values of dopamine in the brain will definitely reduce and acetylcholine levels will increase. So there's an imbalance with respect to the neurotransmitters. Because of this imbalance per se, when you are going to start treating these patients, the treatment of these patients, the drug that you will be using would be one benzhexol, and benzhexol is not going to increase dopamine in the brain. It is an anticholinergic drug, so it will basically bring the ratio of the neurotransmitters to equivalent levels and thereby reduce the disability of the patient. From the examiner's perspective, they also would like to ask you regarding trihexyphenidyl. Now, why they find a fancy for that? I just want to say that that's because the name is relatively longish and our examiners have a bit of a sadistic attitude, so probably they love to ask for trihexyphenidyl as well. Another cause can be calcification of the basal ganglia. Now, I'll say a very interesting thing here. For calcification of the basal ganglia, you see, if a person is having hyperparathyroidism, then there would be increase of calcium in the body, and that will explain the calcification of the basal ganglia. But if there is hypoparathyroidism, then there will be excess of phosphate in the body, and even that will cause calcification. When I say this, the query of most doctors is that, sir, more calcium can cause calcification of tissues, understandable. How will increase of phosphate contribute to calcification? The logic behind that is that if the multiplication product of calcium and phosphate, if the multiplication product of calcium and phosphate is more than 55, see, the point is either calcium can be more or phosphate can be more, either of the two. If calcium is more or phosphate is more, if any of the two is increased and the multiplication product goes more than 55, the two will chelate and will start getting deposited in the tissues, and therefore you could be having bad news about in the form of calcification of the basal ganglia. It could be both hyperparathyroidism as well as hypoparathyroidism, and if you go to the endocrinology section, I have mentioned about this. The next cause that I want you to remember is toxins. Well, there are many of them, so let's remember the important ones. One is carbon monoxide, second is carbon disulfide, and then insecticides also. You see, like recently in 2020, when COVID struck, there were a lot of locusts, coming over to India from Pakistan. In fact, the joke was that Imran Khan has sent locusts as a gift to India in the form of biological warfare. You see, when these locusts are coming, what are these fire brigade people doing? They're just spraying malathion, insecticide on the trees where these insects are living at night so that they can kill them. But you see, if you do indiscriminate spread of insecticides, then ultimately those insecticides will come in the food chain also. That is why nowadays there's a fad about organic farming. In your society, lots of time these vegetable vendors would be coming, putting up a sign saying, okay, this vegetable is 4 times normal because it is organically produced. The message of mine is that insecticides, when they enter into the human food, into the food chain and come in the human body, one, they can cause aplastic anemia. DDT is incremented for that. And another possibility can be development of Parkinsonism also. So I definitely want you to, remember the fact that why organic food is such a craze nowadays is because of these reports which are saying that even insecticides, if they come in, that can contribute to problems. So the insecticide that we are talking about here is anyway MPTP. So I'll not go into the full form, but just remember insecticides per se can cause aplastic anemia as well as development of Parkinsonism. And another toxin which I want to highlight, but I'll use a separate number to highlight it because of the importance of this, is manganese. In fact, this is taught even in biochemistry class also, that element toxicity contributing to Parkinson disease is, or Parkinsonism is, the answer is manganese. The learning till now is that Parkinsonism is a broad term. One of the causes of it is Parkinson disease. That is going to be primary Parkinsonism / typical, because it has a very good response to levodopa. Whereas you could also be having secondary. The points that I've written in point number 2, 3, 4, 5, they are the ones which are mainly responsible for development of secondary Parkinsonism in a patient, with obviously manganese being relatively important. Now, before I move to the next slide and enumerate some more causes, I want to talk a bit about carbon monoxide poisoning. You are familiar from your forensic medicine that carboxyhemoglobin will be having 1000 times more affinity for oxygen as compared to oxyhemoglobin. So obviously there would be a anemic hypoxia developing in the patient. Now, obviously, post-mortem, you know about cherry red lips. I don't want to talk about that. I'm going to speak about what is going to be the ante-mortem presentation of a person of carbon monoxide poisoning before he dies. You see, he's inhaling this gas, oxygen is going inside, or the oxygen availability to tissues is lesser. As a result of it, the basal ganglia will malfunction. So before this person dies, what is this person gonna experience? Because there have been instances when these people have been saved by you by giving hyperbaric oxygen therapy. So these patients felt as if their whole body has become very stiff and they could not move. Why? Because the basal ganglia malfunction will cause extreme amount of rigidity as well as bradykinesia. So the person says that I felt like I should get out of the bed. I was having a splitting headache because oxygen deficiency always causes a headache. But he says my body was failing me. And lots of time these patients might actually keep on lying in the bed and unfortunately die. And that would be a horrible way of dying, that you know that you are not feeling okay, but you can't even get out of the bed. So lots of time you would have read this term also, no? Paralysis agitans. That just highlights the fact that in these patients, obviously I'm not saying that there is any paraplegia, quadriplegia, flacidity. All I'm saying is the muscles in the body very stiff, but he's not able to control the activity of the muscles, and the body is so stiff that he can't even get out of the bed as well. That would be bradykinesia or even a akinesia manifestation, which resulted in expiry of this patient. However, if he's lucky, then you very well know that if the person is brought in time to the hospital, you can definitely give hyperbaric oxygen therapy. The concept is that hyperbaric oxygen therapy will increase the amount of dissolved oxygen in the blood and thereby take care of the requirements of the tissues. So there is a possibility that carbon monoxide poisoning survivors might actually tell you regarding symptoms which were akin to that of Parkinsonism. The next point is again very important, and that is what I was speaking from the perspective of Muhammad Ali, that people who are in body contact sports can have damage to the substantia nigra. So it may not be only boxing, it could be even a road traffic accident. The message is it could be physical trauma, it could be compromisation of the blood supply. Like when you talk about midbrain stroke, there's a possibility that in midbrain stroke, the stroke might increase to involve the substantia nigra as well. There could be a tumor in the midbrain that could be impinging on substantia nigra. The logic is that damage to substantia nigra causes Parkinsonism. The causes can range from stroke to blood vessel damage to tumors which could be pressing, or even normal pressure hydrocephalus. Looks surprising, no? In normal pressure hydrocephalus, the hydrocephalus component, right? There's an expansion of the ventricular system that could actually impinge on substantia nigra. I hope you remember that in normal pressure hydrocephalus, we have talked about reversible dementia. So today I've just upgraded your information by telling you that the triad for normal pressure hydrocephalus includes three features, that is DAI, dementia, ataxia, incontinence. That is the triad, that is the traditional feature. But in later stages of normal pressure hydrocephalus, even substantia nigra hampering can be there due to the expansion of the ventricular system as well. The details that I've told you till now are gonna be for typical and secondary Parkinsonism. Now I come to the most important discussion per se for Parkinsonism topic. This I want you to listen with utmost amount of care, because lots of MCQs that are asked on this topic will actually talk about atypical Parkinsonism. Before I describe the subtypes of atypical Parkinsonism, I want to highlight that when it comes to typical Parkinsonism, you will usually read about questions starting about resting tremors. But in atypical Parkinsonism, whichever variety that I will describe, I will not use the term resting tremor. So whenever you are reading a question of Parkinsonism like features, rigidity, bradykinesia, if resting tremor is missing, that's one clinical hint to the fact that it may not be a typical Parkinsonism. Obviously, you can differentiate by giving levodopa. If you get a good response, it is typical. If you get a poor response, it is an atypical variety. Let's take up the name of this one. Very important from the exam perspective, because our examiners always love to talk about it. We call it MSA, multi-system atrophy. The older name for this disease was Shy-Drager syndrome. This is, I would not like you to note it down because this is old terminology. When I was a student your age, I used to read about the term Shy-Drager, but at the moment the term used is MSA. Now let us look at how the question on this topic will be framed. He will talk about a 60-year-old guy. So the age of presentation is slightly earlier, because traditionally Parkinsonism manifestations will show up by 65 to 70 years of age. So slightly a younger patient is having difficulty in mobility. He's become very slow. The gait has become relatively abnormal. His body is also stiff. He might use words like cogwheel rigidity for upper limb, lead pipe, L for lead pipe, L for lower limb, lead pipe rigidity present, and then will surprise you by mentioning regarding autonomic features in this patient. Now the surprising thing is that when you study about Parkinsonism per se, as a topic, you don't anticipate autonomic insufficiency coming up, so that is definitely to be considered. When it comes to autonomic insufficiency, I first want you to understand that these patients can be having recurrent falls. Now you might say, sir, recurrent falls is a feature of Parkinsonism. What is the big deal? Well, the big deal is that it is not because of per se the problem in the gait which is contributing to fall. He is rather having an orthostatic hypotension. How do I demonstrate that? I will check the BP of this person first in supine position. Then I will request the patient, please stand up. I will not record the BP immediately, but I will wait for 3 minutes and then record the blood pressure to give some time for the compensatory mechanisms to act. If the systolic blood pressure of the patient falls more than 20 millimeters of mercury and the diastolic blood pressure of the patient falls more than 10 millimeters of mercury on change of position from supine to standing, it implies the fact that there is orthostatic hypotension present. Now, traditionally, orthostatic hypotension is what you read with diabetic neuropathy. The least that you expect is that you are going to be having orthostatic hypotension with the case of Parkinsonism. Yes, possible. That is why we're calling it atypical. Other features will be relatively harmless, looking like constipation and recurrent bouts of diarrhea. So that you might even think that this could be irritable bowel syndrome. But the point is orthostatic hypotension does not occur per se in irritable bowel syndrome. The question might then surprise you by saying something very surprising, very weird. He might start writing intentional tremors in the same patient, and you'll be wondering, come on, man, am I reading a question of basal ganglia damage or am I reading a question of cerebellar damage? Because when you talk about a person having intentional tremors, the manifestation intentional tremor is of cerebellar damage. He might start talking about gait ataxia. So you are at the moment confused in your mind whether I'm reading cerebellar damage or basal ganglia damage. So such a disease, which is going to be combination of the two, guys, is technically called as multi-system atrophy. The name is multi-system because there's a combination of basal ganglia manifestation and cerebellar lesions, so it is written as MSAC. The subscript C highlights that there is cerebellar manifestations present. Now I'm changing it to plus minus to say that in lots of cases of multi-system atrophy, there may not be, the word is may not be cerebellar manifestations present. So I'm going to call it MSAP. There are two variants of multi-system atrophy, MSAC and MSAP, that I want you to be comfortable with. One would be having predominantly, along with the bradykinin rigidity component, cerebellar manifestations. Other may not be having it. But when you read a question which initially mimics the question of Parkinson disease per se, but what is the difference? No resting tremor, intentional tremor thrown in, orthostatic hypertension coming in. You have to think in terms of multi-system atrophy. Lots of time in multiple choice questions of multi-system atrophy, he might even give you a MRI head finding as well, which will be, I would say, additional bonus if he mentions. Even if it does not, this is information which is taught in radiology also, that is hot cross bun sign. It mainly highlights the damage involving the brainstem. Most importantly, there's no definitive treatment for this condition. If you are going to start with levodopa, you would be having a poor response, which explains the fact that why have we discussed this topic as atypical Parkinsonism, because typical has a very good response. The next condition will be having recurrent falls. Now, obviously, falls might occur in Parkinsonism, but mostly the falls in Parkinsonism occur forward. I'm going to describe a condition to you where a person might be falling backwards again and again. The condition that I'm describing next in the sequence of atypical Parkinsonism is called as PSP, Progressive Supranuclear Gaze Palsy, and again happens to be a hot favorite of our examiners. The part of the brain that is involved in this case is a part of the midbrain, that is superior colliculus. Well, what is the function of superior colliculus? It is vertical gaze. By vertical gaze, I imply I can subconsciously, my eyes can look down on the computer screen that I'm writing, then look up at the camera. So my eyes can go up and down. Or if I'm walking on an uneven surface, my eyes can subconsciously go down, look at the uneven surface so that I can catch my step if I tend to fall. So if vertical gaze in any person is hampered due to supracolliculus damage, then the chances of falling will definitely increase. Most of the time, the MCQ will begin by describing a 60-70-year-old man, and he would say impaired vertical gaze. And most of the time in this particular topic or in this condition per se, you will notice he will highlight impaired downward gaze. You see, damage can be to both downward as well as the upward gaze, but mainly it is downward gaze which will cause more disability, because if I cannot look down and if I cannot see the ground that I'm walking on, if the ground is uneven, I can definitely have chances of falling. Let me describe it in a form of case to you. I'm having a 60-year-old male today. He is becoming relatively slow, like his son and daughter is saying that as compared to what my father used to do, early morning walk, now I find that he walks very slowly in a peculiar fashion. There's a bradykinesia component coming up and the body is also relatively, I would say, stiff. He also says that whenever we leave him alone, like he went for a morning walk yesterday and even today he had a fall and somebody, the security guard, had to come and pick him up, and this has become a habit. Another interesting thing that will come up will be, and maybe his grandchildren would have noticed, that our granddad is becoming messy in eating food. I'll explain why I'm saying messy in eating food. You see, suppose there's a plate of rice before me or noodles and I'm eating, right? I have to pick up the noodles with the help of a spoon near it, bring my mouth. So when I bring the spoon up, my eyes can actually see that my hand is coming up so that I can open my mouth and put the food containing the spoon which is containing the food in my mouth. In this case, the coordination will be lost because you see the vertical gaze is hampered. The person will not be able to see the spoon coming up, and there's a possibility that when he brings up the spoon containing rice or noodles, the spoon might go and hit the chin and the food will spill over onto the clothes of the patient. The term that I'm using and will help you understand about this disease better is called as dirty tie syndrome. What I mean by the word dirty tie syndrome is there would be recurrent spilling of food on the dining table in this person. And the reason for spilling of food, as I highlighted before you, is the vertical gaze that is affected. And in multiple choice questions, just to make it sound sophisticated, he might use the word eyelid apraxia. If he begins the question by saying impaired downward gaze in an old man, anyway, most guys are able to crack the question. So the examiner also realized that the success rate of people getting this question right is increasing. So he changed the word. Instead of writing impaired downward gaze, he just mentioned the word eyelid apraxia, which is a good pickup point again. Another feature that might be present in these patients is because the vertical gaze is hampered, right? Especially the downward gaze. So person might raise his head slightly like this to look down in an effort to look down. So hyperextension of the neck is again noticed in a lot of these patients. When he's sitting on the examination couch in front of you, the patient, instead of keeping his head level with you, he might actually be sitting like this because he wants to look relatively down. Imaging will be helpful for diagnosis of this condition. In typical Parkinsonism, it's a clinical diagnosis, but in atypical, we prefer doing neuroimaging. The neuroimaging in this case will be able to identify the damage to the midbrain, that is the superior colliculus. Now, superior colliculus is per se very small in size. So, to draw parallel analogy with the superior colliculus, which is damaged small in size, they have actually talked about a hummingbird. You see, hummingbird is not found in India. It's a very small bird that will drink nectar of the flowers. So, the technical term used is hummingbird appearance. I mean, I personally feel that if we will give a MRI head finding in the exam, then all the clinical information will become redundant and you can solve the question by this radiological terminology itself. The examiner knows that. So lots of time you may not be having this benefit of MRI head finding be given in the question. If he gives, well, that's a bonus for you. Another feature that he included in the MCQ instead of hummingbird appearance was electrooculography finding of this person, which was mainly done because he was having a vertical gaze that was hampered. The technical term that was written was square wave jerks. So I just want you to remember these two very classical terminologies: square wave jerks on EOG and hummingbird appearance on an MRI head. Well, obviously you will not mess it up with the square root wave sign. We have talked about square root wave sign with respect to constrictive pericarditis and restrictive cardiomyopathy in the cardiology component. So there is absolutely no reason why it can ever be missed. And most importantly, this condition will also be having poor response to levodopa. So I'm just doing the honors by writing that. But if you read a question that begins by saying poor response to levodopa, the question is half solved. That means that you don't need to consider any of the items that I've discussed from point number 1 to 6. You need to focus on mainly 7 and 8. That is, either the answer to the question would be MSA. How would you pick it up? Autonomic insufficiency. And if he talks about poor response to levodopa and then talks about falling backwards, hyperextension of the neck, eyelid apraxia, or just says the classical term impaired downward gaze, you have cracked the question as PSP, progressive supranuclear gaze palsy. Now explain a very surprising condition to you where a person is actually smoking a cigarette. So he put the cigarette to his lips, lighted the cigarette. He is trying to he's trying to smoke, and involuntarily, look at the surprising thing I'm saying. He put a cigarette to his lips with his left hand, or let me say right hand, right? He puts a cigarette to his lips with his right hand, then lights up the cigarette as well. And then involuntarily he says, my left hand takes out the cigarette from my hand and throws it. He says, I feel as if this hand is not mine, this is not under my control. Or my friend offered me a cigarette. I took up the cigarette from my friend in my right hand, put it to my lips, lighted it also, but then involuntarily my left hand took out the cigarette from my lips and threw it away. This very surprising condition that I'm telling you is called as alien hand syndrome. The surprising feature of this is that the person is saying that I feel as if this one hand, it could be left, it could be right, the hand does not belong to me. I feel as if the hand has a brain of its own. You see, the hand has a brain of its own in a sense that cigarette smoking is injurious to health. I want to drink a cigarette, but my other hand is taking out the cigarette from my lips. Well, this peculiar manifestation is seen where the damage is in the corpus callosum. You see, corpus callosum coordinates the activity between the left and the right hemisphere, and the condition is called as corticobasal degeneration syndrome. This corticobasal syndrome, or CBS as they traditionally call, is also called as alien hand syndrome. And the reason why I have highlighted this particular condition is because this would be having tau protein. Now, The surprising thing is that when I started the discussion, I told you tau protein is encountered in patients of Alzheimer's disease. But what are we studying? Parkinson disease. And I'm teaching you tau protein in a atypical Parkinsonism called as corticobasal. Obviously, in corticobasal syndrome also, might be having standard features like rigidity coming up. He might talk about cogwheel or lead pipe rigidity. The standard features are very much there. But then this involuntary movement of the hand, where he says that the hand has a brain of its own. It looks as if the hand has pulled out magically the cigarette from my lips and thrown it away. And it's only an example of a cigarette. No, he might be trying to eat something and the hand, takes that item and throws it away. That could also be a possibility. The message is that I am trying to now explain to you taupathies, guys. I want you to remember that progressive supranuclear gaze palsy is an example of atypical Parkinsonism but does not have alpha synuclein protein. It will be also having tau protein deposition inside the neurons in the cytoplasm of the neurons. The terms that I want you to remember now at the moment is taupathy. And taupathy, what are the diseases which are to be remembered? The mnemonic can be remembered as ACP. So let us just jot down the names. I have already sensitized you to the fact that when it comes to a person of Alzheimer's disease, there would be Hirona bodies, and tau protein is the composition of Hirona bodies. Right now, you have learned corticobasal syndrome or corticobasal degeneration is related to taupathy, and then so is PSP, that is progressive supranuclear gaze palsy, which is discussed in the previous slide where you had this classical hummingbird appearance present. So definitely one, I would like you to remember this information, though this is discussed in pathology also, diseases having a taupathy. Additional fact that I can make you remember here is Pick's disease. The new name for Pick's disease is frontotemporal dementia. In Alzheimer's disease, the damage is happening in the temporal and the parietal lobes, but in this case, it would be frontotemporal. And the details of frontotemporal dementia again are mentioned towards the end of Alzheimer's disease per se. So these examples that I given before you, especially fact number 7, then 8, then 9 and 10, they are the ones which are called as atypical Parkinsonism. Towards the end of the etiology, I also want to talk about a neurodegenerative disorder which is found in pediatric age group. I hope you recall the fact that when it comes to Wilson disease per se, which is a disease of excessive copper in the body, basal ganglia can again be damaged. So I am just trying to teach you from the etiology domain that I'm not saying that Wilson is a cause of Parkinsonism, but I'm saying Parkinsonism like features. I'm not saying Wilson is a cause of typical Parkinsonism, atypical or neither secondary. All I'm saying is Wilson will also have neurodegeneration. So it is a neurodegenerative disorder that I want you to primarily remember. Wilson, which basal ganglia is damaged, guys? Right? We are talking about basal ganglia damage, no? The basal ganglia damaged in Wilson disease is lenticular nucleus. That is why we call it hepatolenticular degeneration. So another neurodegenerative disorder has just been discussed at the moment. And then a counterpart of Wilson disease, like I taught you, Wilson disease will be having copper deposition in the lenticular nucleus. I'm talking about iron deposition in the basal ganglia. This is also a neurodegenerative disorder which would be encountered in pediatric age group. In fact, is a differential diagnosis of Wilson. The question is open, guys. Which disease do you read about iron deposition in the putamen and is a differential diagnosis of Wilson? Your answer would be given as neurodegeneration in the brain. The word is NBIA. The word is older name for this is Haloverden-Spotts disease. But nowadays the word Haloverden-Spotts disease is not used because of Nazi association. The doctors, Haloverden and Spotts were Nazi doctors who were actually incriminated in killing of Jews, the Israeli people. So they've removed the word Haloverden-Spotts and now they call it neurodegeneration in the brain with iron accumulation. The reason why I'm teaching you these peculiar names will also come very clear to you in few seconds from now. Reminding you once again, the word Haloverden-Spotts disease is a differential diagnosis of Wilson, but primarily because both the diseases will be ending up with basal ganglia damage. These are pediatric onset neurodegenerative disorders. Adult onset we discussed were like Alzheimer's disease or neurodegeneration occurs in Parkinsonism. Huntington's chorea will come up very soon in adult onset. The reason why I have discussed these two neurodegenerations, guys, is for their MRI findings. You would be familiar with the MRI findings, no? Giant face of panda appearance with respect to lenticular nucleus damage and eye of the tiger, like the eye of a animal like tiger etc., will shine in the dark Similarly, iron hair will shine on a MRI. So you see magnetic field, no? So iron is gonna be affected by the magnetic field. So eye of the tiger appearance on a MRI head is very characteristic finding that you will be seeing with patients who are having these neurodegenerative disorders. These are two pediatric onset neurodegenerative disorders. They've just been mentioned towards the end to sensitize you to the fact that even these disorders would be having a basal ganglia damage present. Let's take up one more. In this case, the neurodegeneration will be occurring in the caudate nucleus. The name, I think you could actually, I could have said it before also, but now I'm talking about Huntington's disease / Huntington's chorea. And from chorea, what do you know that caudate nucleus is the one that is affected? This disorder is asked in the exam. Why? Because this will be having a excess of dopamine. The surprising thing is in Parkinson disease, there's a dopamine depletion. This disease has a dopamine excess, and therefore it is being discussed after completing the varieties of Parkinson disease before you. Guys, I have described to you primary Parkinsonism, secondary Parkinsonism, and atypical Parkinsonism. Entry number 7, 8, 9, and 10, they are very important from the exam perspective, in a sense that he will say all are examples of atypical Parkinsonism except, so you just need to get the names right. Then I've talked about pediatric onset, and then I've talked about rather a person who's 40 to 50 years of age. In fact, the age of presentation of routine Parkinsonism is like 60s, 70s, 80s. This is going to be younger. Let us now study what is the problem in this disorder, Huntington's chorea. It's an autosomal dominant disorder, so therefore will be expressed always in the next generation. The defect is located on chromosome number 4. The gene involved is called as Huntington gene, and the protein will be Huntington protein. I repeat the fact once again. The gene involved is Huntington gene. This Huntington gene causes malfunction of ubiquitin. Ubiquitin is a protein in the cytoplasm neuron which is responsible for cleavage and destruction of various end products of metabolism. Due to this gene, there is a malfunction of ubiquitin. Due to malfunction of ubiquitin, there will be an abnormal protein accumulating in the cytoplasm of the neurons, and this abnormal protein, which is not present in the cytoplasm neurons of yours and mine, is called as Huntington protein, and this will cause misfiring of the neurons, and the end result is the person will start developing involuntary movements. In Huntington's chorea, there is two problems occurring. One is GABA, the inhibitory neurotransmitter, is less. If inhibitory neurotransmitter is less, obviously the movements can occur in the body, because you see normally the motor activities are suppressed by GABA. Second, there is an excess of dopamine. Why have I highlighted the excess of dopamine is because if you will give levodopa to this chap, what is going to happen? He will deteriorate. If you give levodopa to this guy, he'll deteriorate. Guys, I'm teaching you a disorder where levodopa is contraindicated. Rather, you will be giving a dopamine depleter to this guy. So while I write down the clinical features, you guys from your pharmacology knowledge have to tell me regarding the drug of choice for Huntington's chorea, which is the dopamine depleter. The message for you guys at this junction is Huntington's chorea is taught in pathology domain because it is a disorder of trinucleotide repeats. Other examples of trinucleotide repeats that you should be familiar with are like myotonic dystrophy and Fragile X syndrome. A disorder of hexanucleotide repeats. I hope you recall that, right? Which disorder have I discussed in neurology with example of Stephen Hawking, which can be having hexanucleotide repeats? Your answer is motor neuron disease / a subtype of it called as amyotrophic lateral sclerosis. If you've not gone through this, you can definitely go down in the subsequent part of the app. When you scroll down, you will find about motor neuron disease also, just above channelopathies, where I've talked about a hexanucleotide disorder, whereas trinucleotide repeat disorder, the problem in the gene is trinucleotide repeats, is also encountered in Fragile X and myotonic dystrophy. Focusing on this disease per se, guys, you will always read about anticipation. Meaning of the word anticipation is that the severity of the disease will increase in successive generations. You see, please appreciate the fact that like if grandfather, father and grandson, all three are having the disease, because it is autosomal dominant, so will run in the family tree. If you compare the severity of the disease in father as compared to grandfather as compared to grandson, the grandson will be having the most severe disease. I mean, with every generation, the severity of manifestations will keep on upgrading. Now, the problem in this chap who's 40 to 50 years of age is that he was fired from his job. Why? Because he had two problems. The first problem that crept up was involuntary movement in his hands, that is chorea. Chorea is a fast involuntary movement, whereas ethiotosis is a slow involuntary movement. So I just want you to remember the word fast at the moment. Well, to explain chorea, I can put it like this: like when I'm writing on the board at the moment, or on my iPad at the moment, then my other hand is stable. No, it's not that my other hand is having a continuous movement, right? Myoclonus has jerky movement. It will occur, it will stop. If I talk about focal seizure will occur and will stop. But when it comes to chorea, it might actually persist on a long-term basis for large number of hours or almost for the whole day. This fast involuntary movement will definitely cause difficulty in, for example, typing on a laptop or maybe fiddling around with a phone. And half the job nowadays is done on a laptop and on a phone. So, I mean, professionally, this guy is not doing great. And then he starts having features of initially short-term memory loss, like he starts forgetting that his boss told him to make a PowerPoint presentation. Lots of time these patients might be having behavioral issues also, like he might become aggressive, he might actually start fighting with people, he might actually urinate in the lift, because you see dementia that comes up here is mainly subcortical dementia. Apart from this, on physical examination, the body will become stiff, so ability to climb up stairs, ability to do routine tasks will be hampered. Person will become slow, so by the time he reaches the washroom in the morning, the pressure in the bladder might be so much that he may urinate in his pants, and family members are worried adult man has become incontinent. There is no problem with the anatomy of the bladder, no problem with the anatomy of the rectum per se. It is just that the control of the body is not very much there, so even the adult person might require a diaper to be used. Now, because you are seeing a relative early onset of the disease, which is worsening with subsequent generations, and this combination, I think, will do the trick for you. I've already highlighted that in the lecture of Alzheimer's disease, that combination of dementia with chorea, even if it does not talk about subcortical dementia, no, will definitely tell you that this is not a traditional question of Alzheimer. Alzheimer does not present at 50 years of age. Neuroimaging will definitely be done in this case. So now let us look at which animal or bird the neurologist, or rather the radiologist, wants to incorporate. So in this case, thankfully there is no animal or bird they introduced a car. The funny thing is, a radiologist slash neurologist both are imagining things in the brain. Last time they were imagining a bird, then they imagined a bun, a McDonald's bun. Now they're imagining a car, that is a boxcar ventricle. So, well, radiology people always, try to keep themselves in good humor. Maybe because they don't get access to talk to people or patients per se, no? Not that I'm against any branch. All I'm just saying in the lighter vein is that these terminologies will definitely aid you in your diagnosis. For the treatment of this condition, guys, I gave you sufficient amount of time to actually think about a dopamine depleter, and the dopamine depleter is tetrabenazine. Please appreciate the fact, guys, that when it comes to Parkinson disease, we can definitely give levodopa, but in this condition already the dopamine levels are spiking, so you would rather be using a depleter that would be asked in the exam, that is tetrabenazine. These three disorders, Wilson is discussed separately in the liver section. Then additional detail is NBIA, which is alternative name for Haloverden spots. Huntington's chorea are also neurodegenerative disorders which have a relatively early onset, but they do not belong in the classification of typical or atypical Parkinsonism. So if you check out the table in Harrison, he's talked about typical Parkinsonism, atypical, secondary Parkinsonism. In secondary, he's talked about conditions like drugs or carbon monoxide poisoning, insecticides, manganese, or example of Muhammad Ali that I gave, that was trauma. So you just need to get the orientation right regarding what kind of Parkinsonism is he asking about, because that will actually decide the answer in the questions. Like for example, if he starts talking about, I'll just highlight the fact once again. Like suppose you read a question in which he talks about a guy who's having problems with his gaze and having recurrent falls. Like suppose he talks about this eyelid apraxia, or he says slow saccades. You are anyway aware of saccades from ophthalmology. Here the fine movement of the eyeball will be hampered. So whenever you read these phrases, guys, eyelid apraxia, slow saccades with impaired vertical gaze, especially the word downward gaze being hampered, that should definitely put some stress in mind that he's talking about a supranuclear. Why supranuclear? Because cranial nerves are not involved here, no? It is above the levels of the cranial nerves. Supranuclear gaze palsy occurring in this gaze, and the problem is in the midbrain. I shall now be summarizing the findings of some important disorders that we've discussed just now, that is progressive supranuclear gaze palsy, multisystem atrophy, and Huntington's chorea or Huntington's disease. Huntington's has been discussed separately because this anyway has a dopamine excess. The main points to be remembered are which area of the brain is involved, what are the important radiological findings, and most importantly, what will be the clinical pointers in the question. In progressive supranuclear gaze palsy, the area of the brain involved happens to be superior colliculus, because of which the vertical gaze is hampered. Multisystem atrophy will be having involvement of the brainstem, which will explain why in this condition autonomic insufficiency can be present. And in Huntington's chorea or Huntington's disease, it is damage to the caudate nucleus per se. Let us now practice regarding the important radiological findings present here. It was a bird that was being visualized in the midbrain, that is hummingbird appearance. For multisystem atrophy, it was a McDonald's bun. Maybe the radiologist was hungry at that of time, so hot cross bun sign. And Huntington's chorea, they were imagining a car in the ventricle, so a boxcar ventricle. Now comes the important pointer from a radiological domain plus the clinical one. So if we encounter a question which is going to be talking about features of Parkinsonism, but then talks about specially impaired downward gaze or eyelid apraxia, which is causing recurrent falls in the individual, it is PSP. MSA, as highlighted multiple times, is autonomic insufficiency. I personally would like you to note down this table on a small sheet of paper on a stick-on pad so that you can retain and remember this information better. And in Huntington's chorea, it would be combination of chorea as well as dementia. This, guys, is important from the exam perspective because quite frequently they'll put up questions on this. Now we will focus on typical Parkinsonism. So my next part of the discussion is mainly focusing on what are the cardinal features and what is the important triad. In patients of typical Parkinsonism, initially they might be having non-motor symptoms, because of which at that particular point of time neither this patient and neither you as a physician will have any kind of impression about what this can lead to in future. In fact, there's a slight controversy between Harrison and API textbook of medicine when it comes to non-motor symptoms. You will notice that in the API textbook of medicine, he has mentioned rather constipation as one of the earliest and the common non-motor symptom of Parkinson disease, whereas in Harrison, first anosmia is written. So both of them are present, but it is just that the order is reversed in the two books. And apart from this, a lot of mood and sleep disorders can also be described initially. At this junction, I do not have any inkling of the fact that what is going to happen to this patient in future, and it is later on that the motor manifestations or motor profile will start developing in the patient. So let's now look at what's going to be the major reason for you to clinically diagnose typical Parkinsonism. I'm dealing with a 65 to 70-year-old guy, and the earliest and the most common manifestation of this disease is resting tremors. You will notice that when I was teaching you atypical Parkinsonism, I categorically remarked there was no resting tremors, but in this case, predominantly resting tremors would be present. The frequency of resting tremors is 4 to 6 Hz, which would be called as low frequency. On this, the query of lot of students is that, sir, above how much would you call it high frequency and less than how much would you call it low frequency? So the figure to be remembered is 8. Like if I am going to describe any tremor to you whose frequency is more than 8 Hz, I will call it a high frequency tremor. In contrast, if the frequency is less than 8, then obviously a low frequency one. Let me just jot down conditions where a person would be having a high frequency tremor. One of the important ones that should be remembered is anxiety neurosis. And the second one to be remembered would be Graves' disease or thyrotoxicosis, since thyroid hormone also has a sympathomimetic profile. Usually the tremor in the two would be something in the range of 8 to 12 Hz, whereas when it comes to intentional tremors or cerebellar damage, it would be about 5 Hz. That is, intentional tremor or cerebellar disease is a low frequency tremor, and resting tremor or Parkinsonism, the typical variety, is also going to be a low frequency tremor. This tremor is usually present only in one hand. It is usually asymmetric and would be present between the thumb and the index finger. So lots of time in the book it will be described as a pill rolling tremor. You see, in Indian literature, I can put it like this: from Indian rural perspective, in fact, I should say that if a person is having involuntary movement between thumb and index finger like this, then the family member might think that my father keeps on counting money all the time. So that's anyway the Indian context. Otherwise, I'm talking about the classical pill rolling tremor, and these tremors will actually worsen with anxiety. Like for example, this old man, he's sitting on the dining table at 1:30 in the afternoon and he's eating his food and he's having this tremor in one hand. So as a result of it, his grandson or his granddaughter is making fun. Like grandson or granddaughter is innocently making fun that, see, the granddad is having this shaking of his hand. So obviously this man may not find it funny and he might get a little angry. So with anxiety, the tremor will worsen. On the other hand, you will notice that when this person will comfortably sleep after having his lunch, then the involuntary movement will disappear also. So one of the highlights of the resting tremor is that it's a low frequency tremor. It's usually asymmetrical. It worsens with anxiety and tends to disappear on sleep per se. Now, the second feature that will come up in this disease would be fairly debilitating because the person will become very slow. Like, for example, if I request you at the moment, please get up from your chair, walk to, let me say, the exit of your house and come back. So you will quickly walk to the exit of your house and come back. It will take you a few seconds, but in this person, this is going to be like watching a movie in slow action. There's going to be bradykinesia, subsequently, there's going to be akinesia to the level that the person will become wheelchair bound. And in the later part of the illness, like in Muhammad Ali's case, I said akinetic mutism. Now, though I use this term even for Alzheimer's disease, in Alzheimer's disease, the mutism component will come because there is the atrophy related to Broca's area also. So, therefore, person really cannot speak. In this case, it's not that Broca's area is damaged, it is the rigidity of the vocal cords, because of which the person will definitely have difficulty in speaking. In fact, earlier you will notice that the speech of these patients will become slow. Like if he wants to say, I want water, so he'll say, I want water. Like it's literally a whisper. He's literally whispering, right? So bradyphrenia is the term that you read sometimes because the person will speak very slowly. He cannot raise the intensity of his voice. He cannot raise the pitch of his voice, unlike you and me, because our vocal cords are obviously flexible. But here, the rigidity component will involve the vocal cords as well. The third feature that is described for upper limbs is called as cogwheel rigidity, right? Jerky, right? And for the legs is referred to as lead pipe rigidity. I did not say jerky movements. I said when you are examining the muscle tone, it would be like a jerky movement that you will be having a giveaway, then a resistance, giveaway, and then a resistance. So cogwheel / a lead pipe rigidity. Lead pipe is primarily for the lower limb. You can remember from the L alphabet, as I had remarked earlier. So usually for diagnosis of this condition, we will be using a triad in clinical practice where we talk about TBR, tremor, bradykinesia, rigidity, and out of the three features, even if two are present, we say that this is a Parkinson disease. Now I want to add an additional feature here where I am saying 1, 2, 3, 4 are the cardinal features of the disease because patients will be having tendency to fall and there will be a postural instability. I will explain to you also how will you elicit the postural instability component, but at this juncture, I basically want you to understand that these four classical features that you encounter in a patient of PD per se are referred in the medical literature or in the textbook as cardinal features, out of which the top three constitute the triad per se. Recurrent falls are anywhere norm because they would be a fascinating gait that I'll again explain to you in my subsequent slide. Let's just recall the features once again. Tremor, bradykinesia, rigidity. If he says which of these is most common, it is resting tremors. If he says which is the earliest, it is still resting tremors. Mind my words, motor symptoms. If he says non-motor, then I've already sensitized you. It is anosmia and constipation. Let us now look at the problems with the gait of this patient. So point number 4 will be explained once again, but in a different way. In some cases, there's a possibility that he might give this clinical profile minus the resting tremor domain. And then he might say there is a poor response to levodopa. That again highlights that we are talking about atypical Parkinsonism. I've incorporated this point mainly to reinforce in your mind that if you read this terminology, then you should think in terms of the differences that we have considered ranging from PSP or MSA. As far as the gait is concerned, I would like you to now keep down your pen and just listen to what I'm saying. You see, if you and me are taking a step forward and there is an obstacle in your course, like there's a stone in your course, a big one, while you are taking a walk in the morning in the park. So if there's an obstacle, you obviously can jump over the obstacle. You can adjust the length of your stride. I mean, the step that you will take, you can adjust the length of your stride and you can either step on the stone or you can step over the stone and you can get over the obstacle. But in a Parkinsonism patient, if you expect that he will be able to overcome this obstacle, well, it is not possible because in these patients, there would be a lot of stiffness in the legs. So there will be definitely the stride will be relatively lesser. In fact, when he will walk, you will be able to hear the soles of the shoes of this guy rubbing against the ground. So I can use the word shuffling gait because there is a rubbing of feet against the ground of this guy. In you and me, when we walk, there is minimal sound of the shoes rubbing against the ground per se. So one of the problems in the gait of this guy is called as short shuffling gait, and there are few more that I want you to continue listening here. My point is that the center of gravity of the body of this person is precariously placed. You see why I'm saying that is, if you just go by physics, no, if you spread your legs, the center of gravity is relatively lower, so chances of falling is lesser. If you keep your feet close together, The center of gravity is relatively higher, so the chances of falling will be relatively more. And you will notice that unlike you and me, I'm just erasing part number 5 here, just for your convenience. Give me undivided attention. When you and me stand, our back is almost straight, but in Parkinsonism, you will notice that the person will be slouched. They would be a stooped posture. When you and me walk, we have a automatic arm swing. We don't even realize, but our arm, right, has an automatic arm swing. In Parkinsonism, both the arms will be having limited or minimal movement and will be partially flexed. In fact, when I showed you the picture of Muhammad Ali initially, I had remarked the fact that if you look at the legs, arms of this person, I'll just use a different color. You will notice that the arms are in a partially flexed position, right? Partially flexed position. That's because of the stiffness that is occurring in the body. The ambulation part is anyway hampered, and the most important problem that will occur in this person will be that if there is any obstacle in the course of this guy, like you sent this Parkinsonism patient alone in the park for walking, and there's a stone in its way, then there's a possibility that he may not be able to adjust the length of his stride. He might actually bump into the object and fall also. So most of the time, leaving Parkinsonism patients alone per se, that too in an uneven surface, is definitely a recipe for disaster. And if you expect this person to cross a busy Indian road, see, in India, when you are trying to cross the road, even if you cross the road from zebra crossing, even then people might just honk on you or might just give you an impression that I'm going to run over you, run for your life. So in India, how do you cross the road? You look left, you look right, and then you run. If you let this guy who's going to walk so slow allow to cross the road, there's a big possibility that he might end up with a possible accident as well. The message is that in Parkinsonism patients, there will be presence of a short shuffling gait. There will be a stooped posture in the patient. Well, I'm not worried per se about the stoop posture, but I'm definitely worried about the ability to coordinate the activity of gait or ability to coordinate the walking, especially when you have to run fast versus slow. The arm swing in this person might actually be reduced or might be totally absent as well. And obviously, as I mentioned, partially flexed arms are there. All these findings that are written here or written here before you are actually also written in the textbook as fascinating gait. So instead of just making you cram the fact that okay, fascinating gait is a feature of Parkinsonism, I basically wanted to explain to you how the disease will manifest, and when this person will be on levodopa, then these manifestations will disappear. He will be able to walk like normal, but when the effect of levodopa will go away, that is when the gait of this person will become relatively slow. So lots of time you would have read about the term on and off phenomenon in Parkinsonism, which basically means that the manifestations will magically disappear once you give medication. And once the effect of medication will go away, because levodopa has a short duration of action, the manifestations in the person will definitely come back. So let us evaluate the walking of this person once again. I again want you to hear me out. This guy is having a slightly stooped posture. I have told this Parkinsonism patient today that, sir, I want to see how you walk. So he's also amused by the fact that this doctor does not have anything else in his life that he wants to see how I walk. I said, sir, when I give you the command, please start walking, and this is the finish line. When you reach the finish line, you need to stop. He's understood my commands. He says, okay, boss, as you say. Now I have given the command, please start walking, but he's just standing there shaking his head. Yeah, sir, I'm walking, but he's not started. So I said, come on, start walking. You will notice that there will be an appreciable time lag. There will be appreciable time lag between the time when you give the command and actually he starts walking, because the body is so stiff, so it's not gonna be able to initiate the activity immediately. In you and me, you see, we can initiate an activity, stop an activity whenever we want. But in this patient, in spite of giving the command, there's a distinct possibility that he may not be able to initiate the activity immediately. Now is walking very, very slowly, so you can hear the sound of the soles of shoes of this guy gradually, slowly rubbing against the ground. So because he was walking so slowly, I picked up my mobile phone, I checked out my social accounts, etc., and he still not reached the finish line. So I said, sir, hurry up. When he will reach near the finish line, I will say, sir, stop. The moment you reach the finish line, stop. In spite of me warning him, he will overshoot, not because there is malfunction of any brakes. The overshooting here is occurring because of inertia. Please appreciate that the body is very stiff. So because of that, starting the activity is also difficult. Stopping the activity is also difficult. He'll overshoot here, and now I will ask him to take a U-turn. And when I give this command, you have to ensure that person should not be alone, either the attendant or preferably you. You should not be sitting on a chair. When you're giving the command of turn suddenly, you should be physically there to catch him. because most of the time when they turn from left to right or right to left, like you and me have axial flexibility, this person might actually while turning fall also. As I highlighted, postural instability has been demonstrated once again in this case, but in the exam he might love to use these terms. Hesitancy. Hesitancy implies that when you gave him a command, start walking, sir, there was a time lag. Like, he is apprehensive over something because the body is very stiff. Sometimes he might use the word freezing. And the word postural instability has been written earlier also, but I'm writing in once again to say that lots of MCQs of Parkinsonism or Parkinson disease per se, he would definitely like to ask you regarding these three terminologies. These three are not a component of any triad. I repeat that they are not any component of any triad. They have just been written together here primarily to focus on what I just explained to you, that when you will examine the gait of this person, you will be able to see these abnormalities that I have highlighted. So there will always be a lot of MCQs of Parkinsonism actually starting with these manifestations. Other manifestations that can be present in these patients are relatively easy because of the rigidity of the facial muscles. They might be words written like mask-like faces. The person will also be suffering from depression. Well, because I'll put it like this: a old man, after retirement, he thought that he'll go on a exotic holiday, he will enjoy his life, and now he is so bad that even going to the bathroom is a big task for him, because he either has to call somebody or somebody has to put him on a wheelchair and take him to the bathroom, or you have to put a diaper. Depression can contribute to development of pseudo dementia. Now, mark my words there. Parkinson disease actually has a subcortical dementia, but here I'm just saying that if you evaluate the MMSE score of these patients, because you see, first you have to diagnose dementia, then you need to identify whether it is pseudo or whether it is going to be subcorticals. What I'm saying is, a lot of these patients might be having depression primarily because their children have deserted them. You see, if a person cannot take care of his personal hygiene, you are putting a diaper on an old man, especially in a poor family. Diaper itself is expensive, so lots of time family members will not take good care of these people. So depression component can come in, and therefore pseudo dementia can definitely be added. The person will tend to speak very slowly. The voice will be literally in whispers, like you will have to bring your ear close to the face of this person and say, sir, what did you say? I can give example of our former Prime Minister Manmohan Singh ji. He was a very soft spoken, right? He was a very soft spoken person. So when Manmohan Singh ji used to talk, right? I mean, if you compare with Modi ji talks very loud. In Manmohan Singh Sarji's case, I would say that his speech was very soft. So in a similar way, like if I want to say I want water, and then I say I want water, so it's a whisper, right? So the whisper part may not be appreciated because there is rigidity of the vocal cords by the family member, and that's definitely something that can be irritating to a non-medico family member, that he might say, why is my father behaving like this? Why is he so unhygienic? Why can't he talk properly? Because you and me are empathic, we are doctors, we understand what is the disease process. Non-medico people don't. Now, if I tap on my forehead with my finger on my glabella at the movement, first time I will tap, I might blink, right? But once I continuously tap like this, I may not blink. Why? Because of the fact that I know it is a non-noxious stimulus. No, I repeated. I tapped first time, I might blink. If I tap second, third, fourth, fifth, sixth time, I'm not blinking. Why? Because I know it is a non-noxious stimulus. But in Parkinsonism patient, you will notice every time you will tap on the glabella, every time blink will be present. This is called as Mersenne sign. Though they may not be actually, I would say, asking you to demonstrate it in the exam obviously, but then yeah, you should be aware of the fact that every time you tap on the glabella, blink would be present, and that's referred to as Mersenne sign. Coming to the treatment of Parkinsonism, obviously we know that the preferred drug would be levodopa. So lots of time in multiple choice questions, instead of asking about levodopa per se, he changed the language and he said, which of the following drugs has been shown to exhibit a neuroprotective effect? What I mean by neuroprotective is that it will prevent the further worsening of symptoms. And well, if you read the textbook, the neuroprotective effect has been shown with the MAO-B inhibitor, that is rasagiline. Now, this is disputed actually. Why I'm saying disputed is because it is very difficult to quantitate whether the person has actually had a progression of symptoms or not. I'll explain a different way. Like, suppose if I'm having fever, and if you give me paracetamol, my fever will completely disappear. So I will tell you, yeah, doctor, I'm 100% fine. But suppose I'm having backache of very severe variety due to faulty sitting position. If you give me a painkiller, I might feel a little better. So I will say, okay, I'm 50% better, I'm 70% better, but that will depend upon my education level and my perception of pain per se. Similarly, here, what I'm saying is that in a Parkinsonism patient, person may not be able to explain to you because he might be even having akinetic mutism. So in fact, it might be a relative who might be saying that my mom or dad is 50% improved or 80% improved. So that can be very subjective bias. So because of the bias introduced by either the patient not being able to tell you accurately of improvement of symptoms, or maybe he's not able to speak and relatives are telling, that is why there's a big query mark with respect to the neuroprotective efficacy of rasajaline. But because this has been asked and is given in the book, I have mentioned about this drug which can actually prevent further worsening of symptoms, and lots of clinical trials on the same are going on. Then he might actually ask you that what drug would be preferred in a relatively younger patient. Then lots of physicians actually prefer starting in younger patients with pramipexole instead of levodopa, starting on pramipexole or ropinirole, mainly because the side effects will be relatively lesser also. Pramipexole and ropinirole are actually going to stimulate the dopaminergic receptor, that is D2. In fact, now we also have transdermal patches of the following molecules available, and that is why in pharmacology you would have gotten this MCQ, that which of the following drug will be relatively long acting. So rotigotine per se has a longer action than as compared to the above two. The advantage is that if you will put this transdermal patch in a younger patient of Parkinsonism, even before he wakes up, then by the time he wakes up, his patch will start working, and therefore the manifestations will be very minimal. So he can himself get out of the bed, go to the bathroom, he can take care of himself, take care of the ablutions part, maybe shave in the morning. On the other hand, if this transdermal patch was not used early morning, then this person may not be in a position to get out from the bed. So somebody will have to carry this person to the washroom, help him with his personal hygiene, shave for him, brush for him. So that will definitely become tedious on the part of family relatives or family members. So it's always advisable that in a relatively younger patient with a definitive disability, if you put on a transdermal patch even before the person wakes up, then the disability part reduces, and at least he can take care of himself in the form of ambulation, at least take care of his personal hygiene, go to the toilet by himself. In contrast, if I'm talking about a older patient, let me say 70-75 years of age, then we will straight away start with levodopa. Now lots of time there are side effects of levodopa also. To prevent those side effects which you are familiar from the pharmacology domain, we will be giving carbidopa, which is a peripheral decarboxylase inhibitor. One of the big disadvantages of levodopa is that the moment it will be metabolized in the body to dopamine, the levels of dopamine will spike, and once the level of dopamine will rise above normal, then there can be even dopamine induced dyskinesias. I said obviously the dopamine levels in the body of this person was lesser, but when you give the medicine, the dopamine level will spike and then will reach over and above what is actually required. So higher value dopamine can be counterproductive and can cause dyskinesias. We will discuss in a while how to solve this problem of dyskinesias, but over and above this, GI upset and GI intolerance can be present. In fact, lots of time orthostatic hypotension will come. So his son and daughter might actually make a big face and say, sir, this medicine is not suiting my dad, because moment I give this tablet to my dad, he starts puking. To prevent these side effects from occurring, I want to actually prevent the formation of dopamine in the blood. See, the concept is I need dopamine in the brain. I don't need it in the blood per se. If you increase the dopamine values in the blood per se, that is when these side effects will come. So I can be giving a peripheral decarboxylase inhibitor, and the advantage of this is that a combination of the two will reduce or mitigate the side effects. Therefore, as of now, levodopa carbidopa is available as a FDC, a fixed dose combination. Now we will talk about dopamine induced dyskinesia. This is what I said. Suppose you gave the tablet, then the drug values will start rising in the body, the dopamine values will spike, and then obviously the levels will come back and the effect of medicine will go away. What I'm saying is that the therapeutic effect, like let me say this is the time when you are gonna get therapeutic effect in the person. This therapeutic effect will last for only a few hours because levodopa per se has a limited duration of action, and once the values reach in this range, that is above the therapeutic range, then there can be side effects also in the form of dyskinesia. So my objective is actually to flatten out this curve. This curve is having a spike, I want to flatten out the curve. I want to increase the therapeutic effect for longer duration, but I want to reduce the dopamine induced dyskinesias. And for that, they did a bit of study to actually how does levodopa get metabolized in the body. So let's have a look at some biochemistry issues. You see, when you give a levodopa molecule to a person, it will produce dopamine, and then this dopamine will be degraded in the body. So there are some end products of dopamine metabolism which are important. One of them is called as 3-MT. The second one is called as DOPAC, and once these get degraded, it will ultimately result in production of HVA, that is homovalenic acid. You are anyway aware of the fact that vanillyl mandelic acid per se is an end product. VMA is an end product of metabolism of epinephrine or epinephrine, whereas dopamine end product is HVA. And then there are certain enzymes which are going to be regulating it, like catechol O methyl transferase, and another one is MAO-B, monoamine oxidase B. What I am saying is that if I'm going to be inhibiting COMT, if I inhibit COMT, then dopamine will be able to act in the body for longer duration. If it acts for longer duration, the frequency of tablet administration will reduce. If you have to give lesser number of tablets per day, then the side effects will also reduce. So I can obviously inhibit either of the two. I can either inhibit MAO, monoamine oxidase B, or I can inhibit COMET. And the good news is that dopamine will be able to act for longer duration, and therefore the frequency of dosaging of levodopa carbidopa tablet combination will be reduced. And the good news is that the side effect profile will also reduce if you have to reduce the dosaging of the drug per se. Now, what is the COMT inhibitor that we will be using is definitely asked in the exam. So the full form is catechol O methyl transferase inhibitor. Please remember the fact that catechol O methyl transferase inhibitor, or COMT inhibitor per se, the drugs are entacapone and tolcapone. When you look at the names here, that is entacapone and tolcapone, please remember that tolcapone has a alphabet L for London present here. Tolcapone has been found to be hepatotoxic. It contributes to damage to the liver. As a result of it, it has been withdrawn. This is similar to what I was teaching you in Alzheimer's disease, that tacrine has been withdrawn because it is hepatotoxic. Now I'm teaching you tolcapone has been withdrawn because of hepatotoxic potential. So it is mainly entacapone that is recommended for the patient. The advantage of COMET inhibitor is that it will increase the on period. That is, the drug will be able to act for relatively longer duration, and it will reduce the off period. So one of the objectives is to increase the total duration of action. The levodopa carbidopa combo will work in the body, or in other words, I can put it, it will reduce the dyskinesia component, because the curve, instead of going up and down, it would be relatively flattened because the on time is increased, the off time is relatively lesser. When you compare the safety profile of catechol O methyl transferase inhibitor versus MAO-B per se, when it comes to MAO-B inhibitor, yes, it is advantageous. The safety profile of catechol O methyl transferase inhibitor will be relatively better. I mean, when you look at the side effects of the drugs per se, the drugs which are we gonna be discussing in this case are selaginine, then safinamide, and rasagiline. Rasagiline I had spoken even when I was talking about the neuroprotective effect, though it's a little query in a sense that subject bias can come. Now, when it comes to the side effect profile, I want to highlight that the safety of COMET inhibitors is relatively better. Over and above this, to test your pharmacology, they might ask you what drug is used for management of influenza A and is useful also for management of Parkinsonism. You very well know the answer, amantadine. You see, amantadine shows very good activity against the influenza A virus, that is H3N1. It's not effective against bird flu, swine flu, that is where oseltamivir is used. Over and above this, additional drugs to be remembered are bromocriptine, the side effects of which is very frequently asked is Raynaud's phenomenon. The longer active derivative is called as cabergoline. In fact, cabergoline, one tablet can act for as long as 14 hours, so they definitely look like very attractive options. But then we have side effects also, no? Especially with these two, we read about cardiac valvular defects coming up. We read about incidence of pulmonary fibrosis. So you will very well see the fact that the dose as well as the frequency with which they are used is relatively lesser. And for bromocriptine I added, definitely the problem of Raynaud's phenomenon can come up, which can again cause disability, in a sense that if there is a change in the colors of the tips of the fingers, the patient is not going to be very happy about it. So let me just explain the manifestations at this point of time. I am having a 70-year-old male patient. Let me explain this now on a case basis. I am having a 70-year-old guy. He has been diagnosed with Parkinson's disease and is definitely having a disability in the form of, let me say, not being able to change the channels of a television remote, or not being able to dial the numbers on a mobile phone because of the tremor component. He's also become relatively slow. He says, by the time I reach the washroom, sometimes urine is passed in my clothes, and I'm definitely noting a rigidity developing in this guy. The quality of life is hampered. When he's eating, he's not able to finish his meals the way he should, primarily because of the problems with chewing also. In a person who's having a definitive neurological disability, considering the age of the patient, I have started him on a FDC, a fixed dose combination of levodopa as well as carbidopa. Now, because of the side effect profile and to reduce the off period and increase the on period, I have added entacapone. I have also added other drugs that I have just discussed with you, but still the disability of the patient is progressing. The same patient now has become 90 years of age. This patient has been under your care for substantial number of years. Earlier, he was responding to your medication, but now his son and daughter is saying, sir, the disability has actually worsened than what we came to you earlier with. My patient is on full maximum dosages of all the anti-Parkinsonism drugs that I've explained to you, but still the disability is very much there. So family member, primary caregivers are frustrated. You would then tell them that we can do a surgery in this case. This surgery is a revolutionary surgery which will be done with the patient awake. Yes, I'm talking about a awake brain surgery that is called as deep brain stimulation. In deep brain stimulation, the name is stimulation, but actually this is a misnomer. It does not cause stimulation, actually it causes an inhibition. In the exam, he has asked that which electrode in this case will be controlled by the pacer which is present in the electronic device DBS, then it is the subthalamic nucleus. If subthalamic nucleus is not given in the options, then your answer will be given as globus pallidus interna. Alphabet I subscript means interna. Well, I can give a real life example of this. In fact, two of them. One I would like to mention regarding a patient from Bengaluru. In fact, this was about 2 years ago. A doctor had put this on YouTube. So you can just Google, or you can rather put in YouTube search box, you can put the word deep brain stimulation Bengaluru. So this patient, who was actually a guitarist of a rock band, was having these intractable tremors in his hands, because of which obviously he could not play the guitar. So the video starts with the surgeon in the OT asking the nurse to give a guitar to this guy, and he's not able to play. Then the surgery will occur. Obviously, the patient will remain awake, and when the surgery is going on, at that point of time, the surgeon has asked this patient to play once again. And once the electrode hits the right area, you will notice that the coordination in the hands will come back, and the guy is able to play the guitar. I mean, it looks very amazing. The patient is awake, and the neurosurgeon is working on the brain of this guy, and suddenly the hand movements will become relatively better than normal. I'm not saying that it will obviously be just like you and me, but yeah, at least you could string the guitar. Now, another example is from a former United States President George W. Bush Sr., the guy who defeated Saddam Hussein. Well, George W. Bush Sr. was a former United States president, and he became a wheelchair bound patient of Parkinsonism. But I read this article in Times of India that to celebrate his 90th birthday, he desired to jump off a US Air Force plane with obviously a parachute attached to his back, and it would be a tandem jump, like there would be a soldier jumping with him with a parachute on. But imagine a Parkinsonism patient with a wheelchair jumping from a plane at 20,000 feet. Well, how did the Americans ensure that their former prime minister's president's wish is satisfied? They actually did this surgery on him, after which his rigidity component, the tremor component, especially the rigidity component, became lesser, and therefore he was able to cooperate with the soldier, and then he did a tandem jump from a plane. So imagine a 90-year-old guy jumping from a plane, obviously with a it would be a tandem jump. There would be somebody accompanying him, but the point is, I mean, with the disability that we are talking about, if somebody is participating in adventure sports, so you can understand the success of this procedure. In fact, deep brain stimulation has been used nowadays even in patients of depression with suicidal tendencies, even patients of sciatica with intractable pain. So the scope of deep brain stimulation is huge in the forthcoming years, and that's a new approach that we are studying for those who are having medically refractory epilepsy. The basic messages I want you to remember is, though you studied these drugs so many times, is if he talks about younger patient, it is pramipexole, let me say in his 60s. If he talks about a 70-75-year-old man, levodopa carbidopa combination with entacapone, and keep on upgrading the dosages. And obviously you can add additional drugs. Try to minimize the off time, trying to maximize the on time is the basic objective, so that the symptom profile becomes lesser. You definitely will be aided by adding D2 receptor agonists as well. So later on, in an old man, you can add obviously pramipexole, ropinirole, or rotigotone transdermal patch. So if you're adding, you will obviously need dose adjustment for levodopa carbidopa in this case. So you need to fine tune. The drugs here are limited. You just need to fine tune to the optimal usage. And suppose you have exhausted all your approaches, still there is nothing to worry. We have deep brain stimulation for management of these patients. So these are the important details that I would like you to remember for this topic. Thank you so much for learning these facts. I know it was a relatively longish lecture, but I'm sure that you would have learned a lot of facts. Keep hammering, guys. Keep learning. and I shall see you with another topic.